So, good evening, everyone. Hope you are doing well. Today, we are going to discuss a very important guideline, a very important topic as well as in clinical practice. A topic which frequently comes across various endocrine exams, specialty or European board or MRCP, and even the other Indian subspecialty board exams. And today, I'm going to cover this very important topic by citing the Joint British Diabetic Society guidelines, which were published in 2022. So this is the latest update in the management of what we call as HHS or hyperosmolar hyperglycemic state. In the past, it was called HONK, but now commonly referred to as hyperosmolar hyperglycemic state. Let's start right away. So as I mentioned, it will be covering the guidelines and very important topic across all exams. Let's start off with a case. It's an 80-year-old woman admitted to the acute medical admission unit, and she's feeling generally unwell for a week. She had a past medical history of hypertension, high cholesterol, and type 2 diabetes mellitus. Her medications include metformin, which she's taking 1 gram twice a day, sitagliptin, which is a DPP-4 inhibitor, 100 milligram once a day, and amlodipine, she's taking for the blood pressure 10 milligram once a day. On admission, she appeared confused and dehydrated. So very important points here, confused and dehydrated. Her blood pressure was slightly on the lowest side, 100/70. Heart rate was 119 beats per minute. So she's tachycardic, which also means a blood pressure on the lower side, and tachycardia means there is a state of hypovolemia. And that is also confirmed by the things which is mentioned, which is dehydrated. She had coarse inspiratory crepitations on auscultation of the right lung base. HB was 102. Sodium was elevated at 165. You can see that. Potassium normal. Urea significantly elevated, indicating dehydration, 25.5. Creatine also elevated, 172 micromole per liter. Maybe it's a deterioration of her renal function on top of chronic kidney disease as well. Her eGFR has dropped to 23. Venous pH of 7.32. So she is slightly on the acidotic side as well. Even the bicarbonate is 18 milliequivalent per liter, which is low compared to 20 to 29, which is the normal range. Blood ketone 0.6. Blood glucose pretty high at 42 millimole per mole, and her HbA1c seems to be poorly controlled at 85 millimole per mole. So what are we dealing with here? Okay, so the diagnosis is based on the different criteria which we encounter. Number one is marked hypovolemia. Number two is osmolality. We'll look at how we'll calculate the osmolality in the next subsequent slides, and that has to be more than or equal to 320. Marked hyperglycemia, more than or equal to 30 millimole per liter. So clearly our patient here is having 42 millimole per liter. Without significant ketonemia, so in our patient the ketonemia is less, it is 0.6 only. And without significant acidosis, pH is usually more than or equal to 7.3. And in our patient, the pH was 7.32, and bicarbonate of more than or equal to 15 millimole per liter. So in our patient, the bicarbonate, if you can see here, clearly it's mentioned as 18. So all these criteria are satisfied. And this is what we call classically as HHS. So this is basically the definition of HHS and a criteria to satisfy, to label the case as hyperosmolar hyperglycemic state or HHS. A mixed picture of HHS and diabetic ketoacidosis can occur relatively more frequently in clinical practice, in which we will have significant acidosis and we can have ketonemia as well. We'll look at how we'll manage that scenario in the subsequent slides. But HHS is very important to treat quickly. Why? Because it is associated with significant morbidity and higher mortality. In fact, the mortality of HHS is around 15 to 20%. And this is a common question in the exams. It is definitely having a significantly higher morbidity and mortality compared to DKA, and therefore should be diagnosed promptly and managed intensively. I marked a big star here because all these clinical features are extremely important and frequently come as a part of question in the exam. And this is the clinical criteria for HHS. Now, how do we estimate the fluid loss in a patient with HHS? Again, very, very important for the exams and in clinical practice as well. The fluid loss is estimated to be around 100 to 220 ml per kg. So that will be around 6 to 13 liters for a 60 kg individual and 10 to 22 liters for a 100 kg individual. The electrolyte loss is also equally important to note. Sodium loss is around 5 to 13 millimole per kg. So that will come around 300 to 780 millimole for a 60 kg and 500 to 1300 millimole for a 100 kg individual. Chloride loss is around 5 to 15 millimole per kg, and potassium loss, very, very important as well, 4 to 6 millimole per kg. That will come around 240 to 360 millimole and 400 to 600 millimole for a 100 kg. To avoid rapid fluid replacement, it is recommended to aim for a positive balance of 3 to 6 liters by 12 hours, while the remaining replacement of the estimated fluid losses should be replaced over the next 12 hours. So we are had to replace around 6 to 13 liters, out of which 3 to 6 liters by 12 hours, and then remaining over the next 12 hours will be appropriate. So we look at the step-by-step management of HHS depending upon the time intervals. So let's look at the 0 to 60 minute time interval. Here 0 is at the time when IV fluids are first commenced. Okay, so this is very important. Let's look what do we start with. We start with 0.9% sodium chloride and we let 1 liter run over the first hour. This is the first phase of 0 to 60 minutes. Consider more rapid replacement if SBP is less than 90. And of course, we need to be cautious in elderly where too rapid rehydration may precipitate heart failure, but insufficient may actually fail to reverse the acute injury. That's why we need to do the right balance. Now, a very important thing, that's why I made a big star here, is about the criteria for using IV insulin in context of HHS. Only commence insulin infusion quickly. We'll be going through these statements repeatedly in the next slides as well because these are very important for exams. So only commence insulin infusion quickly in the following circumstances. If there is HHS along with ketonaemia. Okay, so basically like a mixed picture. Blood ketones here are usually more than 1 but less than 3, okay, millimole per liter. And the ketones which are measured in this context is 3-beta hydroxybutyrate. Or if the urine ketones are also positive but less than 2+. And provided that the patient is not acidotic. Not acidotic means the pH is more than 7.3 and bicarbonate is more than 15. Then in this scenario, we can use half the standard dose of the insulin infusion, which is 0.05 unit per kg per hour. Okay, so for example, if it's a 60 kg individual, then it will be 3 units per hour basically. Okay. On the other hand, if there is significant ketonemia, so here we are talking about 3-beta hydroxybutyrate more than 3 millimole per liter, or if the urine ketonuria is present plus it is more than or equal to 2+, alongside a pH of less than 7.3 and a bicarbonate of less than 15 millimole per liter. Now this will call as a classical mixture of DKA and HHS. The above one, not so much because the patient is not acidotic, okay? But here classically we can call it as a mixed DKA and HHS picture. And in this scenario, we should use the DKA guidelines, which we had already discussed in our previous video of DKA. And that can also be seen and referenced in the JBDS website. And in this scenario, the amount of insulin infusion, what we need to start is like what we'll do in a patient with DKA. So at the rate of 0.1 unit per kg per hour. So for example, if it's a 60 kg individual, it will be 6 units per hour, straightforward, okay? Assessment is very important. Does the history suggest of sepsis, vascular event, or recent change in medication? Assess the degree of dehydration. Examine for source of sepsis or evidence of vascular event. For example, this patient had crackles in the right ways. Maybe the patient is having pneumonia. If the infection is there, that may be the precipitating cause, and that needs to be treated as well. Mini mental state examination for cognitive assessment. Our patient was confused. Assess for the contraindications for low molecular weight heparin. Why we really need to give this patient low molecular weight heparin? Because it is a highly thrombotic state, HHS, and that's why it's important that all these patients receive low LMW heparin. And I'll tell you the more guidelines in subsequent slides regarding this. Always assess for the foot risk score. There is a high risk of foot ulceration in this scenario. Assume high risk if the person is obtunded or uncooperative. Ensure always that the heels are offloaded, and always make sure that you're doing daily foot checks, because there is a high risk of foot ulceration or a thrombotic state with HHS. Investigation-wise, capillary blood glucose, this we are going to do it hourly because the patient will be on insulin. Suppose the patient is on started on insulin infusion, we need to do it hourly, irrespective of that fingerprint point of care, venous plasma, blood glucose, urea and electrolytes, measured or calculated serum osmolality. So this is how we calculate the osmolality. As I mentioned in the criteria for the diagnosis of HHS, it should be more than equal to 320. So how do we calculate that? So 2 into sodium plus glucose plus urea. Until the urea is available, calculate using 2 into sodium plus glucose. Recalculate the osmolality once urea is available, and then use the formula of 2 into sodium plus glucose plus urea. Now, if we go back to our question, if you just multiply 2 into the sodium, it will already be more than 320, which will already satisfy the diagnosis. Plus, if you add the urea plus the glucose, the value will be much, much, much higher. So clearly, this patient is having HHS. Then we do the venous blood gas for pH, bicarbonate, lactate, electrolytes, capillary blood ketones, finger prick point of care, FPC, blood cultures, ECG, chest X-ray, urine analysis culture, CRP if indicated. Monitoring wise, establish monitoring regimen appropriate to the individual, generally hourly blood glucose, sodium, potassium, urea, and calculated osmolality for the first 6 hours. So again, a very important topic for exam, monitoring of a patient of HHS. So hourly blood glucose, sodium, potassium, urea, calculated osmolality, hourly for the first 6 hours. Then 2 hourly osmolality if the response is satisfactory. What is satisfactory response? If the osmolality is falling at the rate between 3 to 8 milliosmol per kg per hour. And always chart the measured or calculated osmolality, continuous pulse oximetry, continuous cardiac monitoring also considered. So again, a very important thing, how to monitor hourly and then 2 hourly. Now let's move on to the next 60 minutes to 6 hours. Okay, so again, our aim is to achieve a gradual decline in the osmolality. So what is this? Between 3 to 8 milliosmol per kg per hour is our target. Okay, now always use 0.9% sodium chloride. Again, a very favorite question for the exams. And then we'll look at one scenario where we should switch to 0.45% normal saline. Otherwise, the standard fluid which is used even with high sodium in HHS is 0.9% normal saline. The aim is to give a further 0.5 to 1 liter per hour, depending on clinical assessment of dehydration versus the risk of precipitating heart failure. The target, as I mentioned, to achieve positive fluid balance of 2 to 3 liters by 6 hours. Again, measure glucose, urea, electrolytes hourly, and calculate osmolality. As I mentioned, this we are doing hourly for the first 6 hours. Now, very important scenarios which we are going to look at now. If plasma sodium is increasing, but osmolality declining at appropriate rate, what is appropriate rate? 3 to 8 milliosmol per kg per hour. Then you just continue the 0.9% normal saline. So this is itself a scenario for exams. So if plasma sodium is increasing, but osmolality is declining at appropriate rate of 3 to 8 milliosmol per kg per hour, continue normal saline should be your answer. Second, if plasma sodium is increasing and osmolarity is also increasing or declining at less than 3 milliosmol per kg per hour, so in this scenario, always go and look for checking the fluid balance. This should be the correct answer selected in the scenario. If the positive balance is inadequate, then very simply the answer should be increase the rate of infusion of 0.9% sodium chloride. Third scenario, if the osmolarity is increasing and the fluid balance is adequate, you found out that, oh, the fluid given is appropriate, then only consider switching to 0.45% sodium chloride at the same infusion rate. So this is an extremely important concept. So in this scenario, your plasma sodium is increasing and your osmolarity is also increasing, and you have made sure that your fluid balance is adequate. Only in this scenario where these three criteria is met, then consider switching to 0.45% sodium chloride or half normal saline at the same infusion rate. Okay, so this is very important. If osmolarity falling at the rate more rapidly, like exceeding 8 millimole per osmol per kg per hour, our target is between 3 to 8, then we should also consider reducing the infusion rate of the IV fluids and or insulin if it was already commenced. Now, if glucose is falling less than 5 millimole per hour, also check the fluid balance. This is the first scenario, okay? If positive balance inadequate, then simply increase the rate of infusion of 0.9% sodium chloride. Fluid replacement should always be adjusted for those who are less than 50 kg in body weight or with pre-existing heart and renal disease. More cautious fluid replacement is necessary. Example, 0.25 milliliter per kg per hour as recommended by NICE. So in patients with less body weight or with pre-existing heart or renal disease, always be cautious about the fluid replacement. I'll tell you some more scenarios about the glucose falling and increasing in that regards in the next slides. And in that also we'll look at different scenarios which come up in the exams. From the above top here, we are clear about the osmolarity because many questions come surrounding this paragraph, and that's why I have marked it as a star. Only start IV insulin once fluid replacement is adequate and glucose concentrations have plateaued. Starting an IV insulin infusion too early could result in a circulatory collapse. So this we should keep in mind. And insulin should only be started in the scenarios which we mentioned in the previous slide. If positive fluid balance is adequate, commence low dose IV insulin as a fixed rate of insulin infusion at 0.05 unit per kg per hour, or if already running, increase the rate to 0.1 unit per kg per hour if the glucose concentrations are not falling. So we already looked at the scenarios for the usage of insulin when we looked here, and this is another criteria. Only start IV insulin infusion once the fluid replacement is adequate. If the fluid replacement is adequate and if the blood glucose concentrations are still not falling, then the insulin infusion can be started at a fixed rate of 0.05 unit per kg per hour, or if this was already running, then we can increase the rate to 0.1 unit per kg per hour. So the free view of this particular lecture has ended. For access to this full lecture session, please subscribe to my lecture series, which is total of 60 lectures till date. These will be provided access to via paid subscription plan, and all the paid subscribers will be given a lifetime access to all my existing 60 videos lectures, which are already on the YouTube channel, plus all the upcoming new videos. So whatever lectures or sessions I'll be doing in coming weeks, months, and years, all of them will be given access to in the same subscription plan. So for the full subscription details, please email me on mazirules@gmail.com or WhatsApp me on 009715574344794 and have the same number on the Telegram app as well. Just to give a brief overview of the full lecture series, so it includes different topics across diabetes and endocrinology, For diabetes itself is there are around 19 lectures which I've done across different topics which are useful for the exams as well as for the clinical endocrinology practice. In terms of high yield topics for specialty exam and European board exam, there are around 9 sessions which have covered all the previous exam recalls as well as all the high yield topics and themes which are frequently encountered in the specialty exams and the European board exams. In terms of thyroid, apart from the thyroid cancer guidelines, which were recently published, plus there are other sessions on different topics related to thyroid across the spectrum of thyroid disease. In terms of adrenal as well, covering all the important topics or sessions which are frequently encountered in exams and in clinical practice. There are 2 very good sessions on lab endocrinology by Dr. Velmurugan, very helpful for those preparing for DM endo or DNB endocrinology as well. In terms of pituitary also have covered all the important sessions on all the important topics which are frequently encountered in clinical practice and the exams. There are a few sessions on the inherited endocrine syndromes as well. Very important sessions on reproductive endocrinology, about congenital adrenal hyperplasia, gynecomastia, hirsutism, PCOS, diagnosis, evaluation, management. There is sessions on calcium and bone metabolism, on familial lipid disorders, and sessions on pediatric endocrinology as well. So just to let you know that there are many more sessions coming up, and as I mentioned, that in the same subscription plan or same subscription fee, you will be provided access to all my existing 60 lectures plus all my forthcoming lectures. So thank you very much for subscribing. Thank you very much for supporting.